Tebentafusp reduces the risk of death by 49% in metastatic uveal melanoma, with median survival reaching 21.6 months. Afami-cel achieves a 39% response rate in patients with previously treated synovial sarcoma. Join Dr. Mehmi, MD of the Angeles Clinic, as he explores these therapy advances and more. In 3, 2, 1. What is TCR-T therapy, and how does it use engineered T cells to fight synovial sarcoma?
So TCR-T therapy for synovial sarcoma is the recent approved therapy for patients with synovial sarcoma who've progressed on prior lines of therapy. And it's using engineered TCR, T cell receptor, that has a higher affinity for its receptor complex. That allows better T cell activation, leading to better tumor control, overall survival advantage, as demonstrated in Spearhead-1 trial.
How well does TCR-T work for melanoma patients who have tried other treatments based on recent trial data?
Well, we are looking for approval in cutaneous melanoma for TCR-T based options. But we already have an approval in metastatic uveal melanoma patients with HLA-0201 positive patients who haven't seen prior therapies before. And that trial, it was an international trial, led to overall survival advantage in uveal melanoma. Now, coming forth to skin melanoma, cutaneous melanoma, there's an ongoing PRISM-MEL 301 study that's a phase 3 study comparing Tebentafusp, another TCR-T, in combination with nivolumab versus nivolumab with relatlimab or nivolumab alone. Earlier phase data in about 30 to 40 patients presented by Dr. Hamid at ASCO 2024 did show progression-free survival and overall survival benefit and disease control for cutaneous melanoma with when Tebentafusp was given with nivolumab. It was a single-arm study, and now that is the foundation of the phase 3 study that's ongoing.
What are the main side effects of TCR-T, and how are they managed in synovial sarcoma or melanoma cases?
Most of the TCR-T adverse events or side effects tend to be the cytokine release syndrome of varying degree. A lot of these issues can be of low grade, and they improve, for example, fever, hypotension, tachycardia. Those type of situations improve with symptomatic therapy like a Tylenol or acetaminophen with antihistamines, hydration. Rarely these patients will need support from more intensive care setting like pressors, and rarely ventilation with intubation. But most of the time these are early grade issues, cytokine release syndrome, easy to manage, that are directly linked to therapy. Now, when you're getting cell-based TCR-T, you will go through low-dose lymphodepletion chemotherapy that can cause its own issues with myelosuppressions, including anemia, leukopenia, thrombocytopenia, and they tend to improve within about 7 to 14 days after therapy. But again, patient will need support through that, let it be for febrile neutropenia, for anemia, or thrombocytopenia.
What future approvals or trials are coming for TCR-T in synovial sarcoma and melanoma?
So for synovial sarcoma, there are ongoing studies looking at other markers than MAGE-A4, NY-ESO1, and some of the other antigens that will be used to design the TCR-Ts. In melanoma, the ongoing studies are already looking at engineered TCR in the IMADIX IMA203 study, and for TCR-T antibody-based therapy, Tebentafusp, again, mentioned it earlier in PRISM-MEL 301 study. It's an ongoing study, phase 3 study, that is looking at Tebentafusp with nivolumab versus either nivo alone or nivo in combination with relatlimab.